Hi, good evening, everyone. Welcome back to our session of webinar again on a Wednesday night. I'm Dr. Betty Tay from Beatinghurst, and I have with me my good friend and old colleague of mine, Dr. Mastura. We used to work together some years ago, and now she has ventured out to her own center, of course, which has recently started. Maybe she can explain more about and introduce herself. Mastura?
Okay, hi everyone. My name is Dr. Mastura, as Dr. Betty has just said just now. So I'm a consultant oncologist at Hospital Picasso. And thank you, Dr. Betty, for the kind introduction and inviting me to speak on this platform. And I chose this topic because I see that it is a very important topic. I see an increasing number of young breast cancer patients in clinic. So at least at Hospital Picasso, where we have been operating the last 10 months in Petaning Jaya, look at our database from, just an example, yeah, from June last year to April this year, for out of 400 surgeries that we did for early breast cancer women in our hospital, about 11% were below age 40. So this is higher than the usual statistics, which is about 6%. So that's why I discussed with Dr. Betty and we decided on this topic. So I'll be happy to talk to you about that today.
A very important topic indeed.
Hmm. So I will share, can I share
Yeah,
the,
sure. Go ahead.
I'll have the slides to present to you. Okay, so this is breast cancer in young women, all right? Okay, so we know this, that breast cancer is a global health threat and the leading cause of cancer among women. And according to WHO report in 2018, it affects about 2 million women each year. And there is this growing burden of cancer that also affects the women in Asia, including Malaysia. So in Malaysia, it accounted for about 34% of all cancers among females in Malaysia. And we also have a high mortality to incidence ratio of 48%. That means every two women that is diagnosed with breast cancer, one may die from the cancer. And for our Malaysian women, almost half of all the patients that present in our country present in later stage. So breast cancer incidence in our Malaysian multi-ethnic society, I would say, the incidence vary between the races in our country. So that's 1 in 22 in our Chinese women, followed by 1 in 23 in Indian women, and 1 in 30 in our Malay women. This is from the Ministry of Health statistics. So our women have a lower breast cancer survival rate in comparison to at least Singapore, for example, or other well-developed countries. So you can see that in this slide that the Malaysia is only about 66% in terms of the five-year breast cancer survival rate. So we have to do better here, right? So before we discuss young women with breast cancer, we have to know what is breast cancer and what is it actually, how does it develop? So when a normal cell in the breast divide, so there might be errors. There bound to be an error that occurs when the breast cells undergo division. So the error in the DNA is what we call mutation. So this mutation, when they happen repeatedly, multiple mutation, and if they are not repaired, they are accumulate over time and then they will change, and it sort of gives the cell the ability to have uncontrolled growth, and then of course it become cancer. So cancer basically you know besides uncontrolled growth, it also has the ability to invade the neighboring tissue and then metastasize, means it spreads to the other distant organs. And then, of course, it can cause death. And that's why cancer is so important, right? So what is it about breast cancer in young women then, since we know what cancer is? So basically, who are these young women with breast cancer? What is their age? So the age that we consider as a young breast cancer has been basically less than 45 years of age, but there have been some sort of different cutoffs used in international literature. So some says it's less than 30 years, some says less than 35 years, less than 40 years, or they say premenopausal women are young women with breast cancer. But we have consensus guideline from bodies such as ESMO that define the women that are considered as young breast cancer women as those who are less than 40 years of age. So this is basically, if you look at the graph here, it's a significant portion of our breast cancer patients, because you can see that from our Malaysian statistics, our the age of onset of most common cancers in Malaysia here. And you can see that for breast cancer, which is the blue thing here, it starts at about 25 and starts to peak at about 45 to 50 years of age. So we have, of course, so we have a large number of patients that are considered to be young breast cancer women in Malaysia. So what causes the cancers in these young women? Okay, what are the risk factors basically? So are they different from the other breast cancers who are older? So several risk factors are implicated in developing breast cancer in young women. So I like to classify them into lifestyle risk factors, or genetic risk factors, or reproductive risk factors, or some what we consider as iatrogenic, means that medication that we give for patients that may cause them to have breast cancer later. So the lifestyle risk factors include physical activity. Okay, this among the physical activity that has been associated with breast cancer so far has been basically like if you have increased physical activity, it has been shown to reduce breast cancer risk. And this physical activity is not like every day. You just have to spend 3 hours per week to do some exercises that has been shown to reduce breast cancer risk. So there are other lifestyle risk factors that we can modify to reduce our risk, such as your body mass index, or obesity, or being overweight, alcohol intake, smoking, and maybe poor diet. So overall, basically, obesity is associated with increased risk, not just breast cancer, but also other cancers and other health complications. And in fact, for our patients who have breast cancer already, we tell them not to, to manage their weight and not to increase weight, because it has been improved to reduce recurrence as well as increase survival. So there have also been studies conducted to look at alcohol consumption. And this has, of course, alcohol is associated with breast cancer in young women. So this is basically drinking alcoholic beverages at least like maybe twice a day. And beer has the highest, risk, while spirits is like the lowest in terms of severity. And then the role of active smoking has been associated, but it's not so clear as like in alcohol. So basically, if let's say you drink and you also smoke, then of course that is worse. And if you do that when you are younger, or you do it even at younger age, then that's even worse. So earlier exposure. Other than that will be the reproductive factors. So like for example, we have early starts of having menstruation, and then late menopause, and we have late age at childbearing. That means now, if let's say you have the first child at age 35 and above, then you have higher risk of breast cancer. And if you breastfeed your children less, or if you have less number of children, then all this actually increases the risk for breast cancer. Of course, there is the genetic risk as well, and this one is what you may have basically heard about, the BRCA mutation, for example. This is just one gene, but there is high penetrance genes, intermediate penetrance genes. That means that these are genes that you inherit from one of your parents that causes you to have at higher risk of breast cancer in your lifetime. So in young women diagnosed with breast cancer, those typically under 40, a significant proportion of them, ranging from between 5% to 20%, may carry these genes, and that could be the cause of them getting the cancer. For example, BRCA1 or BRCA2. Okay, so this is important for us, because when we know that, it could influence how we, treat them, and how we counsel them for monitoring or surveillance, and even for reproduction, counseling for them, because when they have children, each child that they bear may have 50% chance of carrying the gene. So yeah, this is all really, really important aspects for young breast cancer women. And we must also know there's also a stigma about, hereditary testing. So some patients may not want to test. And, the insurance industry in Malaysia is also quite backdated, where they may not want to support women who probably, have this genetic preponderance. Okay. So I just want to bring this slides here, because I do get a lot of questions in my clinic with regards to whether this causes cancer or not. So like usage of deodorant, or maybe, underwire bra, or if you if you use microwave, or you use that microwavable plastic, sugar, beef, everything, COVID vaccine, soy, having a house next to the TNB electrical tower. So all these are basically myth. It has not been proven to cause, breast cancer in young women, in older women, in anyone. So it's okay, to use all this. So do the young breast cancer women present differently than the older women? Okay, so the answer is no. Of course, what's common is common. So how do women present?
Okay, we
Breast
cannot show this. We need to.
Oh, sorry. Then I will go down. Okay. So they have breast lumps, they have nipple discharge, they have, lumps in the armpit, and they will go on to the triple assessment as per other women to rule out that this is breast cancer. So means that they go on to have the physical examination and then ultrasound, mammogram,
Okay, wait,
and of
hold on.
course,
We
the,
don't have your slide anymore. I don't know why.
oh, is it? No?
Yeah, Fiona?
Do you have the slide now?
Yes, we do now.
Okay.
Mhm.
So the presentation is the same, but the assessment of the women might be different. So for example, in young women, the mammogram alone can be challenging because young women have very dense breast tissue. That means that the breast is filled with breast tissue, which appears white on the mammogram, and not like in older women where they have fat. Okay, fat. So sorry, I need to okay, so fat looks black. So if let's say you're looking for microcalcification in the mammogram, so you want white at the background of black so that you can see it. But if you have white against the background of white, then you cannot see it because the background is white. So this can obscure any cancerous lesion. So MRI breast, like the pictures down here,
No,
can
I
do a
can't see your I can't see your slides.
is it? Well, I can see it now. What about down?
Hold on. Fiona, we need to up the slide again, yeah. So I don't know what happened to your slide.
What about now?
No, I can't.
This one? Okay, I'm gonna okay.
I think somebody is Fiona.
Yeah. Hi, Dr. Masura. I think you need to share the slides again.
Okay.
Okay, let me just one participant share at time. Yep. Can you try and share your screen?
Um, okay, now
Okay, fine.
can you see it? Okay, so
Yes.
I'll go down here. All right. Okay. So I'm here where I was talking about how MRI of the breast can do a better job than mammogram in young women to look at the breast lumps. Okay. So we can also use the imaging to look at lymph nodes. So this is to show the extent of the cancer, right? So you can see there how they look like. Okay, so that's okay. So otherwise for young breast cancer women, we use ultrasound to look at the breast as well. And ultrasound is very, is often what we consider as a preferred imaging evaluation. So maybe I can go back to the ultrasound here. Okay, and then it's also widely available, it's cheap, and also, okay, beautifully, there's no radiation exposure to the women. So what we look for are masses with suspicious features. I'm sure there's like irregular shape or maybe spiculated margins on the lesion, and also they will give you what we call the BI-RADS score, and if your BI-RADS score is like 4, 5, then that's very, very suspicious, and you need to have a biopsy. So same thing, after they have done the initial evaluation, we will do the cancer staging. So various ways or modes of doing the cancer staging. This is to be discussed with the doctor, of course, but there's no difference between young women and older women in terms of the staging modality that we use when patients have breast cancer. So we either use CT scan, PET scan, like that. Okay. So, are there any other differences that, that we need to know about the young breast cancer women? So there are. So prognosis-wise, okay, prognosis-wise, the current evidence suggests that breast cancer prognosis is worse for younger women. So there are several factors that contribute to the poorer prognosis, including many of the women present with more advanced stages. That means that they come late. That's probably because their breast is dense. They are not in the screening age group where screening starts at age 40 and above. So they don't go for screening. And they have usually their tumor biology is also like more aggressive. That means that their clinical pathological features are more aggressive. So they are at higher risk for cancer recurrence and death. So they have other than that, the fact that they are young, there's already a prognostic factor where there are many studies that show that when you are less than 35 at diagnosis, you have a higher risk for recurrence and death for breast cancer. And other than that, the association with BRCA mutation, for example, that may increase their risk for relapse once they get the breast cancer. And also that sometimes they may not be able to go on treatment because of certain other social factors. Maybe they are pregnant, for example, or they want to have a child, so they might delay their treatment, and that causes their prognosis to become somewhat worse, other than the usual, clinical pathological factors or late presentation. Okay, so I just give an example, right? So for breast cancer, there are multiple types in terms in terms of their hormone receptors status. So there is a subtype of breast cancer called triple negative breast cancer that basically stage for stage has the worst survival. So for this triple negative breast cancer, that is like the worst type of breast cancer, a large number of patients who are in this group comes from the younger age group. So this type of cancer affects younger patients, and they are also associated with BRCA mutation. So this cancer that has poorer prognosis, like rapid growth, they recur early, they like to spread to the brain, to the lung, to the to the liver. So these often affect younger women. So that's why that's again, telling you how how important young breast cancer women need to be treated as early as possible, or as optimal as possible, so that we can help to improve their outcome. So in terms of treatment, right? So the treatment is also similar. I mean, we don't actually, there's no difference with regards to treatment of their cancers. So they do have somewhat a higher kind of aggressiveness, or maybe a poorer prognosis than other patients. But then the main thing about treating them is to discuss with them their disease, okay, their prognosis, and then what is the required treatment, how the treatment is going to
The slide, please.
Sorry,
Can we change the slide, please?
here?
Because when you show the breast, okay, fine. Because when you show the breast, I will get blocked on Facebook.
Oh, sure. Okay.
Yeah.
Anyway, okay, it's
thought
okay.
about it also, yeah.
So I was saying that treatment is the same for these women who are young, meaning stage per stage, they are treated the same. If they require surgery, they require surgery. If they require, chemotherapy, they require chemotherapy, just like any other women. But they have some concerns that are unique to them, or accentuated by their age, by their basically their stage of life at diagnosis, their fertility, their body image, their sexual dysfunction, and social and vocational role functioning. So all this, is important for us to consider. Okay, so also their, their distress, the psychological distress in this group. So we need to address that at diagnosis, and also we need to address that as we are following up the women. So we need to discuss with them as oncologists, right? Their diagnosis and prognosis, again, that required treatment, how it's going to impact their fertility, how it's going to impact their contraception method, their their active daily living, whether they would like to become pregnant later, how it's going to, whatever decisions going to affect their outcome, all that have to be discussed with them. So basically, in summary, there are multiple unique challenges that are faced by young women with breast cancer, not just risk factor, but also the diagnosis, the treatment, and also survivorship issues. And we must actually, pool resources and, do, okay, sorry, I cannot show that one. So we must pool resources and then, basically put our research where this is sorely needed. So the picture that I want to show here is basically the surgical management of breast cancer, where in young women, we always want to make, try to conserve the breast because that will give them a long-term, good quality of life. And for radiotherapy, for example, when we are irradiating probably the left side where the heart is, we always have to consider that we try not to, irradiate or give a large dose to the heart because they are going to live long and we don't want them to see any potential side effects in the future. Okay, same thing like for chemotherapy. Okay, as much as we can, we discuss the side effects because of course the chemotherapy, the hormone therapy, the biological therapy, the immunotherapy, all that will come without, with side effects. It's not like as easy. So we have to consider all the side effects that they are going to face. New challenges, new changes. Alopecia, problem with eating, problem with bones, okay? And we also discuss about their childbearing potential. Being young, they might not have a partner now, but they might have a partner later. So we try not to, discredit that basically. And so this is just to show that these are the person years at risk for Malaysian female statistics, where you can see that for our Malaysian female, about 1/3 have the childbearing potential. So these patients, right, when they are pregnant, right, the estimated age of first childbirth is about 27, 28 years old. That's also where our risk for breast cancer starts, where in Malaysian women, it starts at about 25 years old. So women who are young, if they develop breast cancer, they can also have the risk or potential to be in pregnancy when they are diagnosed with the cancer. So this is rare. It only happened in 1,000 to 2,000.
Okay, the breast again.
Oh
Next.
my. So, but that as they defer childbearing to a older age because they have to go their career, they have to study, so they defer their childbearing to later. So then you get that cancer in pregnancy, or we have to discuss chemo in pregnancy in these women. So another aspect that is also important other than the possibility of being pregnant and being diagnosed with breast cancer is oncofertility discussion that we have to make with our patients. So when we treat the patients, right, and we need to understand if our treatment is going to cause fertility issues to them. So we have knowledge about, what kind of drugs that may cause fertility issues later. We have knowledge about, the age. So for example, if let's say the woman is less than 30 years old, 27, 28 years old, usually the fertility will not be affected as much. But if let's say the woman is already like nearly 40, then yes, treatment will probably greatly impact their fertility potential in the future. So we need to get these patients to be counseled before they start treatment so that they can be referred to the fertility specialists so that they can do some measures in order for them not to be affected in terms of getting a child later. So for example, you can, this is just to show you that this is established, where if let's say a patient is diagnosed with breast cancer, they can go for oncofertility counseling, and then if let's say they desire to actually preserve their eggs or preserve an embryo or maybe preserve their, get their ovaries to be taken out and then implanted later. So all that can happen. We can also give treatment, and then patients will have the treatment after this is provided to them. Okay. Then once they finish their treatment, we can still go on to give them counseling about the potential for pregnancy 2 years after their initial treatment has completed, for example. Okay, so there are also this issue where women who are now taking on, for example, hormone treatment, they are probably like 2 or 3 years taking the hormone treatment, and now they desire to have a child. So they ask whether it's safe for them to stop the hormone treatment and then start to have a child. So there has been big data that actually show that it is actually safe to allow young women with low risk breast cancer. That means a cancer that is not like stage 3, for example. So low risk breast cancers that can go on to try to get pregnant and safely stop their treatment for at least 2 years, and then before they resume their treatment. Okay, so this is just to show that this is the study that was published that shows that stopping endocrine therapy did not confer a worse survival to these women. So this can be discussed with the oncologist when, you know, the woman desires to do so. So this slide basically just to show that no matter how, you know, how much we talk about all this treatment, we do have some challenges and disparities in terms of our cancer care in our country, and this has been associated with poorer outcome compared to the other developed countries. So, you know, we have our awareness is quite poor. So that's why we are doing this kind of talk, so that we can increase the level of awareness, okay, and health literacy and patient education. So our early detection and screening has to be improved. You know, younger women, they don't have mammogram, but they can go for ultrasound, especially if they have risk, you know, their family history, or they must be able to come to see the practitioners if they suspect anything, you know, lumps or discharge, anything. Okay, and then of course, those who see the patient, for example, our general practitioners, when they see someone who's pregnant and having a breast lump, don't say that, oh, this is, you know, breast cancer changes because of pregnancy, but do evaluate them and refer accordingly when you know or see patients like this. Okay, so of course there will be treatment access barriers, but we are improving in that sense. And please remember that no one treat breast cancer alone. Everybody has to be treated by a team. Breast surgeon, oncologist, there must be a pathologist, radiologist, so on and so forth. And this care has to be coordinated because it's a long-term kind of treatment, you know. And of course, support from the spouse, support from friends, family members, bosses, doctors and nurses, you know, even online support if you may, so that the patient, you know, will carry through the journey as well as possible. So this is just a summary that shows you know, the multitude of challenges in terms of treating breast cancer with young women with breast cancer. So it starts from even, you know, diagnosis, treatment, and also survivorship. So there are various factors that are involved, you know, including treatment adherence, because when patients are young, they have a lot of social responsibilities, they have a lot of family responsibilities, they want to, you know, go far in their career, so they might not be compliant sometimes, and they do not adhere to follow up. So these are very important in terms of treating these women with breast cancer at a young age. And this is what is important throughout their journey having breast cancer. So we try to prevent breast cancer as much as we can. We do all those necessary steps, you know, healthy diet, exercise, ideal weight, no alcohol, no smoking. And we must know what is our history, what is our family history, whether we have risk or not. Go for early detection, get a correct diagnosis, and you know, treat it accordingly, and then go on a good survivorship and surveillance, you know, managing side effects and all that until probably end of life, where hopefully it's like beautiful for you. Okay, with that, I end my conversation or talk today. I'm sorry about the glitch. I didn't know that we cannot show.
No, we can show on Zoom.
Yeah.
So I'm so sorry. I forgot to also warn you, because we live stream to Facebook, and
So they're
Facebook has a
very strict.
quite strict, and I have been blocked a few times and warned a few times. So we do have a question from Leo on Facebook, who asks, how can we screen breast cancer in a patient who is less than 40 years old, with or without family history of breast cancer?
Okay, good question. So those who are like 21 and above, where they can already consent to doing anything, right, without the approval of their parents. So first thing first is they need to know how to do breast self-examination at home. So you can look it up on the online where you can see how they can put there how to fill your lemon and all that. You can go there and learn how to do breast self-examination. Okay, so once you reach probably 25 and above, if you would like to see a healthcare professional, it can be a GP or it can be a breast care nurse, or it can be a doctor, a surgeon, basically, a surgeon, a breast surgeon, a breast endocrine surgeon, so that you can be, they can perform the breast examination for you. And if need be, they will do an ultrasound for you. So you can do that. And until age 40. So you can do that probably once every 2 years, let's say. So this is for people who have no family history. For people who have family history, or people who have there are two categories. One is have family history, one is a carrier of the gene. So if they are carrier of the gene, that means they have been tested and they are carrier of the gene, then they will go on a program, a follow-up program by the clinic lah. It's basically a clinic that will follow them up and will actually put them on either 6 monthly ultrasound and also maybe MRI breast if cost is not a concern. Okay, for those with just family history, same thing. They can actually go for ultrasound, go for physical examination with the doctor. The age at when they start is, for me, is like 25 and above, because that's where the risk starts for our Malaysian women lah. So it's like 25. Usually they're already working, right? Maybe I hope they're already earning, so they can actually go and see a doctor and get their breasts checked. And maybe ultrasound can be done same time.
Okay, I like to say that along the way, funnily, as a cardiologist, because I'm in Beacon, I see a lot of patients with breast cancer. And it's true that a lot of patients are below 40, and many I've seen presented late in diagnosis, not because of them, but because of us. Because they are at the age where they are either getting pregnant or having a baby. And a lot of it was missed because they felt alarmed, but everybody said that it's related to either lactation or because the
Blood ducts,
congested or infected. And I think that it is very important to let everyone know that if you feel alarmed or you are a little bit suspicious, get it checked. Even if it's not by a GP, even a breast surgeon or oncologist, just go ahead and see them straight, because sometimes they are fueled by hormones, right?
Yeah, that's right. So the best way to manage breast cancer is prevention. The second best way is actually for early detection. That means if you can come to get it checked as early as possible, then you can actually get it diagnosed at very early stage, where the treatment is going to be simple as well. And it's not so expensive, and your outcome, your survival is very good. So
I want to ask you, is the survival rate worse in the younger age group? Is the survival rate worse in a younger age group?
Yeah, the survival rate has been shown in many studies to be worse in the younger age group. And again, the reason for that is actually multifactorial. Okay, so mainly it's because of late stage presentation, and secondly, it's because the biology of the cancer is of the poorer type.
I see. So it's a more aggressive cancer, usually. Is it because of the hormone?
I do not think that is mainly because of the hormone. No, it's due to other things. It's due to other factors.
I see. It's not because of the hormone. For example, where they are premenopausal, so it's driven by the estrogen.
Okay, breast cancer in general, about 50% are driven by estrogen, but another 50%, probably another 45% are driven by other factors. For example, it's just a unique, more aggressive cancer biology. For example, HER2 positive or triple negative, which consists about 45% of all breast cancer types, which are not hormone driven. They are just an aggressive tumor biology where changes in the cancer, the breast cells have happened due to multiple factors. So genes, environmental factors, other factors as well, but not just hormone. Hormone is just one of it.
We see. Okay. Would you see a rise in breast cancer? Because from our last census, 55% of Malaysian women are overweight. And I think they are more so in the younger generation of women.
I do see that, Betty, because we are having basically what I consider as a more westernized lifestyle. We eat a lot, we eat more, we eat a variety of food,
Yes.
and we eat more processed food, and then we have less activity because we are on the phones all the time. We have cars to bring us everywhere now. We have escalators.
Yes.
So we are less physically active. And we have early menarche. That means last time, 14, 15, we
Oh,
start to
yes.
have this, right? Now it's like 9,
Yes, true.
9,
It's
right?
early menarche, yeah?
Yeah, early menarche. So 9-year-old now, 9, 10-year-old, they start to have, and then we don't have as many kids, okay? Maybe one or two for almost everybody. And then, yeah, late age at first pregnancy, less breastfeeding because we are working and we have options, right? We have this and that to actually feed our kids. And of course, the environmental factors lah. So there's chemicals in the processed food that we eat, the environmental pollution, then of course alcohol and smoking, and even passive smoking is associated with higher risk for breast cancer.
Oh,
So
I
all,
see.
Mm,
And that has been proven, is it?
yeah, in large studies. So yeah.
Oh,
Mm.
is passive smoking, does passive smoking increase lung cancer?
Yep.
Also increases lung cancer.
But if you compare smoking and alcohol has a higher rate, higher risk than smoking alone.
To get any cancer?
No, for breast cancer, I'm talking about.
Oh, for breast cancer.
Mm.
And may I know, so because I'm a drinker, how much alcohol? Actually, when you say beer, it's actually next to me.
So yeah,
I
so
did not show you,
highest.
now I say it. So
Yes,
I'll ask
yeah.
you, so how much? I mean, what kind of quantity?
So the studies have shown twice a week. They didn't say quantity, but they basically say 14 glasses per week. So
Oh,
that's twice a
14
day. So twice
glasses.
a day.
Huh?
Twice a day. 14 glasses per week. So that's twice a day, right?
14 glasses a week. Oh, means that you have like the French, they would drink for one, maybe for dinner and for
Lunch, maybe lunch or dinner.
yeah. Okay, so I'm about there. Okay, but I'm not young anymore, so is it okay? There's a there is a lady, and she's not a doctor. Her name is Ashling. She says she's in the 5th year of remission.
Yeah.
I've been doing mammogram and ultrasound daily. How long should I be doing this check?
You should do it for as long as you live.
Yes. I think
Yeah,
first,
forever.
of course, congratulations, Ash.
Oh, yes.
And I think 5 years is a good
I will tell my patients
5 years
that,
and counting.
yeah, that's right.
Yeah, 5 years and
Yeah.
counting. So you are a survivor, and then of course do it. Okay. It is
I tell my patients that you will continue to do this until either I will see you until either you die or
either you die or I die. And I'm so like last time like I was young, so unlikely. Now I'm also chances of me dying is higher maybe than my patients. Yes, yes, but it's a good thing. But are there, okay, so the other concept that we like people to know is that sometimes they have to be not just on surveillance for the rest of their life,
And
but sometimes they have to be on medication for life. Do you not, is it true? For example,
uh,
treating like hypertension or diabetes as a chronic disease, and yes.
okay. So, usually if let's say the longest treatment will be the hormone treatment, and we're talking about early stage cancers, yeah? So early stage cancers, the longest treatment is hormone, which is up to 10 years, and then we will stop. But for those patients who are in stage 4, metastatic breast cancer, and if the treatment, let's say treatment A, I won't say what the treatment is.
Yes, okay.
Treatment A is controlling the cancer, right? So we continue on the treatment for like infinity, so long as it's controlling the cancer still, the patient is still willing to take it on. There's no severe side effect that make us stop the treatment, or the patient die from any other causes. So we will continue the treatment. So I think there's a question
Like,
from the medical student here, Betty.
oh, okay, let me see. Oh,
Yeah, medical
yeah,
student.
can I know what are the significance of sentinel nodes?
Rotus node in diagnosing breast cancer.
You sure sound like a medical student.
So actually the treatment is the significance of sentinel nodes. Okay. So sentinel nodes are the nodes in the armpit, in the axilla, that will be the first station where if the cancer wants to spread to the armpit nodes, this will be the first nodes that the cancer will reach. So that is the sentinel lymph nodes. So the significance is if let's say the patients have early stage breast cancer and the surgeon want to do a surgery for the patient, if it's early, that means the cancer is small, there is not much nodes seen or no node seen on the ultrasound, mammogram, or CT scan or PET scan, then they will do a sentinel lymph node biopsy. That means that when they perform the surgery, they inject a dye to the tumor, and the dye will follow where is the first area. If cells want to escape the tumor and go to the node, that's where the node that the cell will stop at first. So they will pick up that nodes and then send to the lab to look at whether there's cancer presence there or not. So that is the sentinel nodes lah. Okay. So yeah, it's important to diagnose if the cancer has spread to the armpit lymph node. So often when during the surgery, if let's say the lymph nodes is involved with cancer, then they may actually clear some more nodes behind that nodes. That's called axillary clearance lah. Okay, so that's important. I think the other question, Betty, is the treatment for breast cancer. How to decide which one to start first, surgery, chemo, radiotherapy, or hormone therapy?
I don't
So,
see, I don't see the question. Okay, you go ahead.
So the question is actually how to decide which one to start first. Okay, so that one will depend on the stage, the type of the cancer, and then the other factors. So basically we look at the patient's stage of cancer. So if the patient is between stage 1 to stage 3, then we say, okay, this patient is going to go for a curative treatment. That means it will consist of surgery. But the question then is, do we do surgery now or do we do surgery after something? After something means chemo lah, chemo or targeted therapy or chemo or immuno that we give before the surgery, then we do the surgery. The reason for that is either because the cancer is stage 3 involving the lymph nodes already, or the cancer is of this aggressive subtype, that triple negative breast cancer or HER2 positive, where we give drugs first before surgery so that the drug will kill the cancer cells in the breast and elsewhere. Either you can see it or not. Okay, so elsewhere, then only we do for surgery lah. So that is an example of how we like sequence the treatment. And the radiotherapy always come after the surgery. So meaning that if you do surgery first and then you follow by chemo and then radiotherapy, then hormone. But if you do chemo first with targeted therapy, then you follow by surgery and then radiotherapy and then hormone, like that. If the patient has stage 4 cancer, then usually surgery does not play that as much important role here because the cancer has already escaped the breast. So we will treat the patient with drugs lah, basically drugs. So if let's say the surgery is no longer playing an important role. Radiating the breast is also not as important lah. The importance is actually to treat the whole person, because the cancer has already, go out of the confine of the breast. So that's I think in a nutshell, that's how it is lah. It's more complex than that, but maybe
Yes,
you
I
can
think
come to
the explanation is, so basically, it's a decision between the surgeon and also the oncologist, and also is very dependent on what they find from the
staging.
investigations that they have,
Yeah, staging, subtype.
staging and everything, yeah. And the other thing that I think I like the patients to know is that now the surgery may not be complete mastectomy, right?
Yeah, that's right.
Yes. So maybe you can explain more from what we taught previously, where complete mastectomy would have a better outcome, and now we just do the surgery that is just necessary to take off the lump.
Okay. So last time, breast cancer did not have very good drug therapy like now. So drug therapy, I would call that systemic therapy. Systemic means it goes everywhere in our body. So last time, surgery was done to remove the tumor, and then radiotherapy, and then drugs, right? So
Okay.
nowadays we understand the biology of the cancer better. We understand the individual characteristics of the breast cancer better. So then we treat the patient with treatment that will render the tumor to become smaller, and therefore you can actually just do a breast conserving surgery for the patient. So nowadays, the breast conserving surgery is what we aim for, but provided that the patient can have radiotherapy after that, because if you do not remove the breast is still there. You do lumpectomy, white local excision, hook wire localization surgery, whatever, but the residual breast is there. We have to give radiotherapy. Okay. So let's say you have your grandmother who's like 90 years old and have a small tumor, but is not able to be on the radiotherapy couch. Let's say Dr. Betty is treating the grandmother having some heart failure like that. So going on the couch for radiotherapy for 15 days is not possible. Then we, as a team, will say, okay, we'll do a mastectomy for this lady, because then we will omit the need to do radiotherapy for this patient. Okay, so that is that. The second thing is, because of the improvement of the drug therapy, right? So recent studies have shown that if you do neoadjuvant, means chemo and targeted therapy chemo and immunotherapy before surgery, followed by surgery, and followed by radiotherapy, versus a mastectomy with or without radiotherapy, the first one is actually better in terms of survival.
Yeah.
So because we have data to show that this is better, then we would offer that to our patients as the what we prefer lah. I mean, we will say, okay, this is your first option. Yeah, this is your first option. Then the second one, like that.
Okay. Ash also asked, is it a better way to track any metastasis via circulating tumor cells test than BC marker test?
Okay. So there is this recent hype about circulating tumor cells or circulating tumor DNA that people are doing in some labs out there in order to konon to actually detect cancer relapse earlier than the usual standard. Okay, unfortunately, sorry to say, but in breast cancer, this is not standard practice at the moment. That means that in the realm of cancer research out there, this method has not been proven to be effective or to impact on your outcome. So that's why it's not yet approved by any governing bodies, and we are not having it in our guideline at the moment. So we don't do that. Not here in Malaysia, not here elsewhere either. So if you get offered to do that as a breast cancer survivor with early stage breast cancer, that means that I don't know. I mean, it's not a valid offer lah. It's probably just a business tactic.
Yeah, she doesn't want to say, but I say it. Probably a scammer. Please be very watchful of what is offered out there, yeah? Be very watchful.
Yeah, a lot of people want
Yes.
to.
I'm so sorry, but there were a lot of slides, and then there were some slides that Dr. Mastura showed of breast with fungating tumor, means the breast cancer have grown out of the skin. And I had to tell her to move forward because not because I didn't want to, I wanted to save you from all the scary stuff, but because of my Facebook. But honestly, those people who had all this fungating tumor are those people who actually have had a diagnosis, gone out there for a period of time, 6 to 12 months, maybe sometimes even less, to seek alternative treatment. Okay. And I can tell all this because I do a lot of echo for patients with breast cancer. And sometimes, yes, sometimes we like to rewind back the time so that we can follow the oncologists and what they offered, but we can't. Okay. And you have to live with that prognosis at that point of time. So any more question? If not, we will close the session. Okay, I have to decide whether I'm going to keep this so far so good that the Facebook didn't warn me. So maybe I will keep it on my live stream because the viewers can be quite a lot and this is a very important topic. So I think the take-home message here is, first, know your risk. Okay, some risk factors are not modifiable. So if you have a very strong family history, okay, get yourself investigated or screened on a regular basis. Two is, there are many, Dr. Mastura have said, many risk factors, okay, that can reduce your risk, okay. I'll try to reduce my alcohol one. I don't smoke. I maintain my weight. So maintaining weight, exercising,
Healthy diet.
yes, healthy diet, okay, are very important changes that you can make to your life. Third, of course, if you are suspicious of any lump, okay, please go and seek proper advice. Yeah. Anything you want to add?
Don't get scammed.
Oh, don't get scammed, yes.
Because it's not easy. So there's no such thing as, cancer is not easy. Cancer is a complex disease. So, there's no, if let's say it's so easy, I would sell them.
Believe me, we will be rich.
And then if someone knows how to treat it so well, right? This person will have won the Nobel Prize already by now.
Yes.
But he hasn't.
True.
He hasn't.
Don't
No
get
one has
scammed.
won. So yeah, so just do the regular way lah, which is to come forward, ask questions. Okay, ask questions. It's okay to seek second opinion if let's say there's something that is not explained to you as well, or maybe there's something that is blurred, or not so clear like that. So yeah, so and third thing is actually please support or advocate for increased health literacy lah, I would say. So don't read old stuff or things that are on the net that are not true. So just help each other. Yeah, support each other. Someone tells you that they have a breast lump, so don't say that this is somebody send bomo, or somebody is jealous of you and try to black magic or something lah.
But
Just
maybe you can, since you're talking about support, of course, there is and I think you are very active also in the support group of patients who have had breast cancer. Yeah. So there is a support group. You can seek out the support group also.
Yeah, that's right.
They do a lot of things. Breast cancer survivor support group.
Yeah, that's right.
Yeah. So thank you, everybody.
Okay.
Join us next week. Next week, I think we have a very interesting topic. I think it's anthropology. Wait, hold on. It's a very interesting topic. Forensic anthropology.
Oh my God.
Forensic anthropology. That's something that I don't know. So do join us. We have a forensic pathologist speaking for the first on this topic, and he's never been featured before. So, and then after that, I go on holiday again. Okay, bye guys. Thanks, Mastura.
Thank you. Good
Okay,
night.
we'll apply for you for a 5 CPD point. Bye-bye. Bye, everyone.